which is a beautiful hospital dedicated to service personnel located in South Colaba. Now, to start with, let us put few things in perspective. This was one of the which I has been contributed by one of the oncologists posted in Port Blair, and this patient had a large chest mass which started growing during COVID times. Due to the lockdown and everything, he could not seek medical attention. And later on, when he actually sought medical attention, there was a large mass in the chest, which was avid in part, and MR showed, however, no extension to the chest wall. The patient was operated by wide local excision, right axillary lymph node dissection, and LD muscle flap cover because there was a large defect after removal of the mass. Why I've kept this case? Because it's a very interesting thing. There was a large size of tumor at presentation in spite of being in an obvious site, but the circumstances at that time put the patient in such a position that he was not able to seek medical attention. In spite of this large tumor, there was no rib or intrathoracic extension. The patient was well preserved despite an aggressive malignancy, and there was a large defect that was left after resection. The defect was closed without any foreign material, so God has provided enough. Finally, the tissue diagnosis of spindle cell sarcoma came. The patient was cured and is on follow-up. So there is an oncological perspective to our work. The first priority is always tissue diagnosis so as to deal with further management of the patient. Our work includes local imaging with CT or MRI, metastatic workup, and clinically to assess whether the patient is a candidate for upfront surgery. So there are many thoracic lesions which can present as an obvious mass on chest X-ray or CT. They can include chest wall tumors, mediastinal masses, and parenchymal lesions. And many a time they baffle us, especially during exams. Diagnosis is definitely not the end, but the beginning of our practice. To initially evaluate a lesion, we have to assess the clinical extent and stage of the disease, optimal target site and modality of first tissue biopsy. Always remember that the first time a biopsy is taken, the lesion is pious or untouched. And that is the best opportunity to get a good sample. Specific histological types, presence of comorbidities and PNS, patient values and preferences are all a little clinical, but radiologists come into a role in first and second part of the assessment. So our work is to confirm whether there is a lesion, to see the location and extent of the lesion, and reasonably guess whether the lesion is benign or malignant before the histopath is done. The modalities we have at hand include chest X-ray, PET-CT, CCT, and MR. Of course, for superficial lesions, ultrasound also becomes very handy modality. What are the radiological questions we have to answer in such a case? Is there a lesion? Where is the lesion? Is it intraparenchymal or mediastinal? If in the mediastinum, whether anterior, middle, or posterior, chest wall or pleural, that is also a possibility always. What is the extent? Whether it's benign or malignant, and are you confident saying that on imaging, or you need a biopsy to give you some more confidence? And as we discuss these questions, I'll show you multiple cases along the way. Is there a lesion? So, whenever we get the 60% of our practice of chest radiology in our departments goes to chest X-ray. After chest X-ray, everything else comes, CT, MR, ultrasound. The first modality, it's like going to a Shiv Mandir and this is the Nandi. You cannot get anything without crossing the Nandi. So chest radiograph, assessment of a chest radiograph, sometimes for first years, it becomes very difficult how to go about an algorithm. So this is something that I've made to hell with disease. Please love, have humor, be sober. So T is for trachea, see the trachea. H is for heart and mediastinum below. Then you go to disease and go to check both the diaphragms, their level, anything above or below the diaphragms. P is for pleura. Assess the pleura in totality. Love is for lungs. Large area, lucent areas on both sides. Assess both lungs. Have is for hyla, both hyla. Assess their shape, character, density. Then comes hidden areas. A lot of things will be spoken about hidden areas in slides to come. B is below diaphragms. Check for any subphrenic abscess or any Chilaiditi syndrome. Soft tissue. So is for soft tissue. So you have to check for any neck masses, any thyroid swellings. And bow is for bones. Always finish with the bones because some small lesions like multiple myeloma or diffuse osteoporosis or sclerotic lesions can be present, and sometimes there is a very subtle finding of either first or second rib destruction, and rest of the chest x-ray is okay. So this is a small mnemonic to help you how to evaluate a chest x-ray. To help with disease, please love, have humor, be sober. So ahead, what lies ahead for you today? We will discuss the mediastinum. How do we divide the mediastinum? What is the difference between these lesions that we see on chest x-ray? Mediastinal lines and stripes, signs to localize mediastinal lesions. A few examples of anterior, middle, and posterior mediastinal masses. Some cases of parenchymal masses and multiple cases. Finishing, we will do a quiz. So what is mediastinum? It is the space between the mediastinal pleura, which extends above from thoracic inlet to the diaphragms below. Anteriorly, it is bounded by sternum, and posteriorly, there are paravertebral gutters and ribs. So on lateral chest x-ray, many of us divide the mediastinum like this. However, there are multiple classifications. So you can choose any classification, but the most common used is ITMIG. There are 4 classifications in vogue: anatomist, Quelsons, Headsman, and ITMIG. Let's see. Anatomists divide the mediastinum into 4 parts: the superior and inferior compartment by an imaginary line traversing the manubriosternal joint and the lower surface of the 4th thoracic vertebra. The inferior compartment then is divided into middle mediastinum, which contains the pericardium and the heart, and the anterior mediastinum, which lies anterior to middle mediastinum. Everything that lies posterior to middle mediastinum becomes the posterior mediastinum. So simple. What about Felson's method of division? Many a time this is asked in Viva. So this is based on lateral chest radiography. A line extending from the diaphragm to the thoracic inlet along the back of the heart gives you anterior mediastinum. So according to Felson method of division, the heart lies in anterior mediastinum. The difference between middle and posterior is formed by a line that connects 1 centimeter behind the anterior margins of the vertebral bodies. So that's the Felson. Then comes Headsman classification. Headsman gives you few anatomic regions which are particular, like the thoracic inlet, the anterior mediastinum, the supraaortic area, the infraaortic area, the supraazygos area, and infraazygos. But this is not commonly used for division and classification of mediastinal masses. The most popular and useful for clinical settings is IDMIG classification, which divides the mediastinum into prevascular, visceral, and paravertebral compartments. This is what we are going to discuss in detail. So here is a lucid example and diagram on lateral chest CT SAG section. The pink part shows you the anterior mediastinum. The blue shows the middle mediastinum containing the heart and the pericardium. There is a line drawn 1 centimeter posterior and connecting to all the vertebral bodies. That is the posterior boundary of middle mediastinum. Everything that comes behind that line is posterior mediastinum. So basically, The paravertebral spaces and the gutters are those that are included in posterior mediastinum. So in exams, it is easy to draw hand-drawn diagrams. This will take just 10 seconds to draw. But this, if you draw this, the examiner will know that what you are talking about, your knowledge is sound. So on axial images, we can see that the prevascular compartment is small. It mostly includes the fat of the in the anterior compartment. The middle compartment contains the heart and the pericardium, and the posterior compartment is formed by the paravertebral gutters. What about a parenchymal mass? It looks very sweet when you get a absolutely book picture of X-rays. However, real-time scenarios are usually not like this. A parenchymal mass would be surrounded by lung at least two-thirds of its circumference. It would make acute angle with the mediastinal or the diaphragm surface. And if you have air bronchogram, that is a sine qua non of a parenchymal mass. So these are the three points that you have to give in exams to say that how to differentiate between parenchymal and mediastinal masses. However, let's go and go one by one and understand the anterior and other mediastinal masses in totality. So to understand mediastinum, we must know about mediastinal lines and stripes. When you start reading this chapter in an article or in book, whether Sutton or Haga, you sometimes feel that it is difficult and you're not able to understand. That's because you have to learn to read things in form of pictures. If you draw them while reading on side by side, things become much more easy. So mediastinal lines are thin, which are less than 1 mm in width, and these are linear opacities which result from contact between two aerated structures. And there is thin intervening tissue on both sides. Mediastinal stripes are thicker than the lines, and because there is some intervening mediastinal structure. For example, right and left paratracheal stripes. Mediastinal interfaces or edges, on the other hand, are produced by contact between aerated lung and adjacent mediastinal structures. So, interfaces in examples include azygoesophageal recess, aortopulmonary stripe, para-aortic line, and cardiac borders. Now, this is a diagram which can be easily drawn in exam, and it shows all the mediastinal lines and stripes. The right paratracheal and left paratracheal stripe, the anterior junction line, which is lower as compared to posterior junction line. The green ones are right and left paraspinal stripes. The azure blue is the azygoesophageal recess, which crosses from one side to the other at D6, D7 level. The dark blue or navy blue is the para-aortic line, and the white one is the AP window reflection or AP stripe. Now, this is the kind of diagram I'm talking about. If you draw small diagrams like this, each may take 6 to 10 seconds to draw in exam. But it gives the examiner a view that you know about your question. And these are very easy to draw as well. They show all the paratracheal lines and stripes that I have just mentioned in hand-drawn diagram form. So here, even on lateral chest X-ray also, you can draw and show these examples. So let's start a little bit explanation about the lines and stripe. This is mostly image based. So just zoom out of your anxiety that it's going to be difficult. It's not. Anterior junction line, as I told you, it is much lower as compared to the posterior junction line. The normal appearance is a thin stripe, thin line that is there at around D4 to D5 level. It is formed because of close apposition of lungs with a thin line of pleura opposed between them. What is the abnormal appearance of anterior junction line? If there is lot of pericardial fat, if there is thymic hyperplasia or any lymphomas, that can cause increased shadow or increased appearance, density, and thickness of anterior junction line, commonly seen on CT. Now look at this anterior junction line. It has got an abnormal appearance because of its deviation of position. Because of hyperinflation of the lung on other side, the anterior junction line has deviated towards the right, as seen on CT as well. Coming to posterior junction line, this is formed by close apposition of lung apices with posteriorly with a thin line of pleura in between them. On chest radiograph, it is seen at D2, D3 level. However, on CT, it is seen posterior to the trachea, like as a thin line. Abnormal appearance of posterior junction line can happen when there are posterior mediastinal masses. As you can see here, there is deviation of trachea and the posterior junction line is obscured or blurred. And on CT, you can see that there is a large thyroid lesion which is going in as retrosternal goiter. So paratracheal stripes, we come to now paratracheal stripe, the right and the left. The right is always very well defined because there is a connection. There is no vascular structures that form the border. On the left side, there are vascular structures, and that's why the left paratracheal stripe is not very well defined or not as well defined as the right paratracheal stripe. Abnormal appearances of the paratracheal stripes can happen if there is right-sided aortic arch or azygos continuation of SVC, mesotheliomas, or retrosternal goiter, as one case I just showed you. AP window reflection. On chest radiograph, there is a small dip that you see between aortic knuckle and the pulmonary artery. That dip is known as the aortopulmonary window. It is seen very clearly on a chest radiograph, which is normal, and also on coronal CTs. However, whenever there is lymphadenopathy, whether it is right paratracheal, pretracheal, or hilar lymphadenopathy, the AP window gets a convex structure, convex outline, and you can very well appreciate the same on CT as well. This is the normal appearance of AP stripe or aortopulmonary stripe. And what happens if there is a vascular structure or a lymph nodes or a lymph nodal mass? It gives a convex appearance to the AP stripe, and the same thing is well appreciated on coronal as well as axial reformats of CT. Next, we come to azygoesophageal recess. Azygoesophageal recess is a thin reflection of azygos vein. As you see, once it shifts from D6 to right side to left side at around D6, D7 level. This reflection, if a well-penetrated radiograph is taken, is visible. However, if the radiograph is less penetrated, it may not be seen. But on coronal CT, it is very well appreciated. However, this is the place where a zygoesophageal recess is there. So anything filling this space will cause obliteration of this recess. What can do that? One example shown here is of hiatus hernia, and that is causing deviation of a zygoesophageal recess. However, such kind of pristine radiographs are difficult to find. And other causes of abnormal appearance of a zygoesophageal recess can be all the causes related to esophageal tumor. Also, if there is benign esophageal tumor like some leiomyomas or just esophageal thickening, if there are esophageal varices in portal hypertension or lymph nodes or hiatal hernia, all can cause abnormal appearance of a zygoesophageal recess. Coming to paraspinal lines. So as you must have thought that when we go to paraspinal lines, we are talking about posterior mediastinum now. So the paraspinal lines are the reflections when the pleura comes in contact with paravertebral gutters and the vertebral column. So if a well-penetrated radiograph is taken, you are able to see till D10, D9, then paraspinal lines are very well appreciated. Any abnormalities in posterior mediastinum can cause convexity or deviation like these. Now, what do we see here? This is one example of thoracoabdominal sign that we are not able to see the lower end of the mass. The paraspinal lines are thickened and they are just diverging from around D12 level downwards. So probably what happens is it may be a tubercular lesion of the vertebra with paraspinal abscess that may cause this kind of appearance. The para-aortic line. So very well seen on most chest radiographs. The shadow of the aorta as it descending thoracic aorta as it goes down and becomes the abdominal aorta. That is the para-aortic line. It is visualized well on left side. There is nothing called right para-aortic line. Then after understanding about these lines and stripes, there are specific localizing signs which you must know when you speak about the mediastinal masses in anterior, middle and posterior mediastinum. And these are known as localizing signs. Some of them are ciliate sign, hilum overlay, hilum convergence, cervicothoracic and abdominothoracic. One example of thoracoabdominal sign I have just given you. So what is the ciliate sign? The favorite and most important question of the examiners. An intrathoracic radiopacity if in anatomic contact with a border of heart or aorta will obscure that border. If the lesion is not anatomically contiguous, it will not obliterate the border. This in by verbatim, you have to say this to the examiner, and because this is mentioned in Sutton, in Granger, in all the standard books of radiology, and this is what is expected. Ciliate sign is very important for you in your clinical practice also and for exams as well, because this is one that helps you to understand and localize the lesions. Next, we come to hilum convergence and hilum overlay. There is a lot of doubt in students' mind about hilum overlay sign. So what happens is that if you see the hilum properly through the lesion is either anterior or posterior to the hilum, but does not arise from the hilum. That is, it is most likely not a middle mediastinal mass. That is all you need to remember. So, if there is hilum overlay seen, the lesion is either anterior or posterior to the middle mediastinum and it is not a middle mediastinal mass. But what happens sometimes is some masses which are very low density and they are arising from middle mediastinum can give the appearance that the hilar vessels are still seen. So all these signs have to be put together. One of them cannot be just taken as a cutoff or a complete a statement which cannot be refuted. Second sign is hilum convergence sign. What does hilum convergence mean? It helps to distinguish a bulky hilum due to a pulmonary artery dilatation from a mass. So vessels can be seen to converge and join a dilated pulmonary artery, right? So in this example, you can see that there is a case of pulmonary artery hypertension, and you can see that this is a dilated pulmonary artery and vessels are coming and joining it on the both hilum. No, now it could also be a vascular lesion also, but this is not a bulky hilum. If the vessels are seen converging towards a dilated pulmonary artery, this is likely to be the hilum is likely to be because of a pulmonary artery dilatation rather than any bulky hilum due to lymphadenopathy or other causes. So that is hilum convergence sign. Hilum overlay and hilum convergence are different things from each other. So don't confuse between both of them. So as I told you about hilum overlay, this is a case from the literature, and you can see the right side, the hilum is seen through the mass. The para-aortic stripe, para-aortic stripe is also very well seen. So that means that the lesion is not middle mediastinal. It is an anterior mediastinal lesion, a large, soft, hypodense lesion, which you can see, It's sitting in the anterior mediastinum and the hilum is well preserved on CT. Next important sign is cervicothoracic. So first I would like you to look at images A, B, C and D. So what you can see on radiograph is that there is a increased density and a lesion on the right side of the trachea, and right paratracheal stripe is widened. But can you see the margins of the lesion above the clavicle? They are not well defined. Now, when you see the CT, you can see that this is a heterogeneous lesion arising from the thyroid gland. Almost the complete gland is replaced by heterogeneously enhancing nodules, and which are also have a retrosternal component. Now, this is a neck mass that is dropping into the anterior mediastinum. So, this is an anterior lesion. The lesions which are located anteriorly will not have a sharp border above the clavicle. So that is one statement. Hear this again. The lesions which are located in anterior mediastinum or anterior neck will not have a sharp margin above the clavicle. Now, look at the set of images E, F, and G. You can see there is thickening of left paratracheal stripe. A convex margin lesion is noted in the left paratracheal region. And what about the margin above the clavicle? It is very well defined and sharp. So what you can see on CT, that the lesion is actually located posteriorly in the left paravertebral gutter. What does this tell you? That means the lesions which have a sharp margin above the clavicle are likely to be located in the posterior mediastinum. Okay? And their DDs will be posterior mediastinal masses like lymphadenopathy and tuberculosis, tubercular abscesses like that, Pott's spine. That is one of the DDs, or neurogenic tumors. So cervicothoracic sign is just one statement that tells you that if the margin, superior margin of the lesion above the clavicle is well defined, it is likely to be a posterior mediastinal lesion. If it is ill defined, it is likely to be an anterior mediastinal lesion and likely to be a neck mass. The reason, what is the reason for cervicothoracic sign? The reason is that the lung apices extend much higher posteriorly above the clavicle than they are anteriorly. Anteriorly, the vascular structures cause the apices of the lung to be flooded and very crowded. But the lung apices posteriorly are much sparsely crowded, and that is why you see the lesion margins much more clearly. So next we go to description, this much about mediastinal lines and stripes. So if you have understood about mediastinal lines and stripes, I have put the chat box on. Can you just give me some comments that you have understood mediastinal lines and stripes? Yes or no? Just type in yes. Okay, I have got few answers. Thank you so much. So I'll go ahead with now anterior mediastinal and masses as such. So anterior mediastinum, I told you, is bounded anteriorly by sternum and posteriorly by the pericardium. Thymus, lymph node, adipose tissue, and internal mammary vessels are its contents. The thyroid gland, and if it extends into the mediastinum, that is retrosternal goiter, is considered to be an anterior mediastinal structure. Disease of contents of anterior mediastinum may cause a mass, and they may be divided into prevascular or precardiac masses. So simple diagram to be drawn in exam. This is for you. This is where anterior mediastinum lies. So what happens if there is an anterior mediastinal mass? There will be obliteration of anterior junction line. There will be hilum overlay sign. There may be a Sillet sign with the right cardiac border. I'll show you an example of this. There is obliteration of cardiophrenic angles, but the posterior lines, that is the para-aortic line, the paraspinal lines, those will be well preserved. Examples of anterior mediastinal mass. This DD you will get in all kinds of books and articles. What you must remember is four T's, that is thymoma, teratoma, terrible lymphoma, and retrosternal goiter. So these are the easy examples of prevascular masses. In precardiac, epicardial fat pad, diaphragmatic hump, Morgagni's hernia are very common. Let's see a few examples. Right-sided retrosternal goiter. Important thing to see is right paratracheal stripe is widened. The trachea is deviated to the left side. So very important indicator of the fact that this is an anterior mass structure, anterior mediastinal mass, and the margin above the clavicle is ill-defined. Same thing seen on axial CT. Epicardial fat pad. So as promised, I am showing you silhouette sign of right cardiac border. The epicardial fat pad is silhouetting the right cardiac border. It is not silhouetting the right hemidiaphragm because of the difference in density of the two structures. Coming to middle mediastinal mass. So this is the diagram that you show for where your medial mediastinal masses will lie. So what happens if there is a middle mediastinal mass? There will be widening of paratracheal stripes, distortion of the azygoesophageal recess, and the AP window. All the vascular masses, aortic aneurysms, pulmonary artery aneurysms, they will cause problem in the AP window reflection. Large lymph node, mediastinal lymph nodes will also cause convexity of the AP window and aortopulmonary stripe. So boundaries, I have told you. Contents, you know that heart and pericardium are the most important ones. Others are the ascending and descending aorta, this SVC and the IVC, and the associated vessels. What is important to note is that phrenic, vagus, and left recurrent laryngeal nerves are also a part of middle mediastinum. I have a case to show you about this. So these are the important middle mediastinal masses which can happen. A few examples: right paratracheal enlarged lymph node, which is causing obliteration of the right paratracheal stripe. Same thing is seen on axial post-contrast CT. Now, I told you that the aortopulmonary window, if there is convexity, always think of some issue with the vascular structures first. So there is convex border of the AP window and it shows a small saccular aneurysm of the arch showing as a middle mediastinal mass. Right-sided aortic arch, though not a mass, but an abnormality that is seen on chest radiograph also and also on the CT. Coming to posterior mediastinal masses, the diagram that you draw for posterior mediastinal masses is this line diagram, neat and clean. What happens if there is a mass? There is thickening, distortion, and disruption of paraspinal lines, distortion of azygoesophageal recess. The para-aortic line will also be abnormal. There is posterior junction line. If there are high masses, there will be obliteration of the posterior junction line and cervicothoracic sign. If the cervicothoracic sign is positive, means that the superior margin of the lesion is having a very well-defined margin. It means that the lesion is extending posteriorly higher up and likely to be a posterior mediastinal mass. Boundaries I have discussed. Main contents include descending aorta, esophagus, azygous and hemiazygous veins, thoracic duct, vagus and splanchnic nerves, lymph nodes, and fat. Let's see few DDs. Main important DDs of posterior mediastinal mass. Always remember neurogenic tumor, aneurysms of descending aorta, all kinds of esophageal masses. Then lateral meningocele and extramedullary hematopoiesis is also a very important DD of posterior mediastinal mass. Coming to a few examples, bronchogenic cyst, a mass obliterating the posterior junction line. It is seen quite higher and you can see the sharp margin above the clavicle. This indicates that likely the mass is posteriorly located. Paraspinal abscess. Can you see what is happening to the paraspinal line? It is completely convex, this one, and also there is a shadow on the other side. So paravertebral mass is causing effacement of paraspinal lines. However, the lateral wall of descending aorta is seen through the mass. You really have to look carefully to pick up such findings, but at least the convexity of paraspinal lines is something that you should not miss. And this can be easily picked up on post-contrast CT. You can see the destruction of the vertebra associated with a large paravertebral mass and along with left-sided pleural effusion. Coming to another example, descending aortic aneurysms. Again, there is convexity of the paraspinal stripe and large aneurysm of descending aorta is seen on CT. So this is how I would draw this chest radiograph and CT. And it would immediately give the examiner very happy and bring a smile to their face and definitely bring me marks. Neurogenic tumors, again, they are posterior mediastinal masses. They cause disruption of left paraspinal line. And on MR, this patient is showing hyperintense, T2 hyperintense left paraspinal tumor. So now we have finished at this point of time, mediastinal masses teaching part. So I'm still have a lot of cases to show you. So let's start with where we come back to where we started from. Is there a lesion? So here is your first case. Is there a lesion? You can write your responses in the in the chat box that where is the lesion that you can see? Okay, somebody okay, you can just say left side, right side, and left lower zone or left upper zone. Retrocardiac, okay, left lower zone. Yes, I've got few answers. Is there any sign that you can tell which helps you to localize this lesion? Left lower zone silleting. Yes. So Dr. Thiru has given me one answer. Left lower zone, the silleting of left card border. That is very important to pick up. This is likely a parenchymal lesion, which is consolidation in the left on the left side. So likely superior lingular segment of left upper lobe is being affected. So this is how you there is silleting of the left cardiac border. Along with that, you can see here small air bronchograms. So those are the sign qua non of consolidation, and I think that should be kept in mind while answering this question. Another case too. So where is the problem in this patient? Right, left, whatever you wish to tell about this case, you can just type in the chat box. Okay, right upper zone, right mid zone, right lower zone, right paratracheal. Very good. So you can see that the right paratracheal stripe is thickened and there is convexity of the right hilum as well. The margin of the lesion above is not well defined. So this is likely to be an anterior mediastinal mass. And that is how you should take your discussion to. Let's see the next case. Can you see something here in this chest radiograph? Yeah, you can type in the chat box whatever you are thinking. Absolutely. Retrocardiac. There is a round increased density in the left retrocardiac region and likely to be either what this could be. It could be even a bronchogenic cyst or it could be a parenchymal lesion. However, this increased density in retrocardiac region is must to pick up. Now, this radiograph, is there something? Okay, it is the chat box is hiding the thing, so I'll put it this side. So this was a 30-year-old male with urticaria and weakness of body, tingling numbness in both upper limbs. Is there any abnormality in this chest X-ray? Or it is normal chest X-ray? What do you think? AP window, it is nice, no? Concave AP window. So it's look pretty okay. Right paraspinal line, no, it's not enlarged. Somebody said normal. I'm so happy. Finally. Okay, fine. So this radiograph was reported as normal. However, the patient was very troubled because he was having urticaria, weakness of body, tingling numbness, and nothing was helping him. We were not able to see any lesion on radiograph. What to do? But it is always said that patient is always right. Okay. So patient underwent a PET CT and there was a small lesion that was sitting in the mediastinum, and this that was PET positive. It was a small cell carcinoid. It was a carcinoid, not small cell cancer. It was a carcinoid. So always remember, if you're not able to find a answer to the patient's question, don't divert them as malingerers or that they are wrong. The patient knows their body much better than all of us. So just give them the benefit of doubt and maybe explore other modalities. Case 5. Any abnormality here? I have moved the chat box. You can see the radiograph nicely. Any abnormality that you can see, you can type in the chat box. Eventration. Okay, so Dr. Sumitra has homed down to the issue of the diaphragm. So left diaphragm definitely is elevated. The cause can be anything, Eventration can be there. There can be some subdiaphragmatic abscess. There can be so many causes which can cause left diaphragmatic elevation. But what was important is I didn't give you history. The patient had come with hoarseness of voice. So now any ideas, thoughts, left elevated hemidiaphragm with absolutely. Somebody gave me the answer. Phrenic nerve palsy? No, one more nerve is located in the mediastinum. Yes, right recurrent laryngeal nerve palsy. Absolutely, bang on. So, right, I just move the chat box. Yeah. So there was a small lesion which was located in the anterior mediastinum, very irregular, heterogeneously enhancing, and it was positive on PET. And this was the cause of the patient's recurrent laryngeal nerve palsy, RLN palsy, because for which they had hoarseness of voice and elevation of left hemidiaphragm. Right. So we come to the case 6. Is there any abnormality in this patient? Or everything is nice and happy? Case 6. AP window. Okay. Anything else? Now look beyond the mediastinum also. The lungs are also beautiful for you to see. That's what happens. That's the meaning of elephant on the image. You start seeing what you want to see. And once you find one finding, you stop seeing the other findings. So see something else. See the lungs also. Increased lucency in left upper zone. Yes, it is present, but that's not the finding I want you to pick up. Fine. So I'll tell you something. Is there something here? Increased density. Can you see? Left mid zone. Yeah. So this was the finding on this radiograph. There was a solitary pulmonary nodule. Now, where is this lesion? Is it an SPN? If it is intraparenchymal versus mediastinal, anterior, middle, posterior mediastinum, chest wall lesion. So now we come to, I'll stop the chat box for a while because I want to discuss something. The definition of SPN as solitary pulmonary nodule, as we saw on this radiograph, was a relatively well-defined oval or rounded lesion, but criteria are there. It should be surrounded by lung. It should measure less than 3 centimeter in size, and it should not be associated with lymphadenopathy, pneumonia, or atelectasis. Only then it is an SPN. If it is associated with any other lesion, it's not a solitary pulmonary nodule. Types of SPN are given in the books and in all articles, and it's important to go through SPN. However, that is not our topic for discussion. It was to deviate from what I was teaching you. Let's have a companion case of SPN. This is a relatively large lesion. So what do you think it is? Let's open our chat box again. Of course, you can see this opacity, but where do you localize it? Is it parenchymal or mediastinal? Round pneumonia is a good thought, or parenchymal? Okay, fine. So I'm getting few answers of parenchymal, but what now I have put the CT also. Can you see? Where is your lesion which we were saying that it is parenchymal? It is here. Okay. So what is this now? This is a soft tissue lipoma. Okay. Whenever you see a lesion, just go and see the patient also. because one of my revered teacher, Sergeant Captain Roshan Pansa, he always used to tell us that treat the patient and not the image. So image can, lot of findings can exist, but it doesn't mean that you have to cure that finding, imaging finding. You have to cure the patient, not the image. Right. So there, the multiple SPNs can happen, and numerous SPNs are like nipple shadow, pleural base lesions, chest wall lesions, skin nodules, and neurofibromatosis. Cloth and screen artifacts can cause spurious SPNs. So that is just a little bit of deviation. But as you remember, to hell with disease, have humor, and love and be sober. So I told you about hidden areas. In chest radiograph, this pink areas that are shown, the paramediastinal areas, the apices, the area below the diaphragm, these are known as hidden areas. And these need a lot of experience on the part of radiologist, the technique of the X-ray, to pick up lesions which are located in these areas. Maybe a high KV would help, and digital radiograph definitely comes handy because you can change the contrast on the radiograph without exposing the patient again and again. So there is a school of thought which says that is the chest X-ray useful? Now we have CT. Should we do CT for everyone? Think about it. Let's go to case 7. So here you have a chest radiograph, and I'm opening the check box again, and you can tell me that where do you see the lesion? And where do you place it? Is it anterior, middle, or posterior mediastinal? Anterior mediastinal. First answer I got, anterior mediastinal. Then second, middle. Then hilum overlay. Very good. Somebody picked up hilum overlay sign. Very nice. Okay. Okay. So you are understanding the topic. Right. So that was case 7 for you. It was an anterior mediastinal lesion and hilum overlay is positive. So kudos to everyone who said that, because it means that you are understanding the topic. Next, intrapulmonary or mediastinal. I told you that these 3 points you have to mention when you are discussing intrapulmonary versus mediastinal masses. The parenchymal mass should be surrounded by lung parenchyma at least 2/3 of the circumference. It should have acute angles with the chest wall on radiograph. And obtuse angle is which is the angle we are talking about. Everybody says acute angle, obtuse angle, but where is the angle? So if it is surrounded by lung parenchyma on all sides, there is no angle. So this is an intraparenchymal mass straight away. Here you can see that on radiograph, it is making an acute angle with the diaphragmatic silhouette and also with the mediastinum. Look at this right pericardiac fat, epicardial fat pad. This angle, that is what we are talking about. So here it is an obtuse angle both with the diaphragm and with the mediastinal margin. So be clear about this. Again, one case. Can you see this? Case 8. Is it a repetition? I guess so. But what I have is, I wanted to show you this, that this was not a cyst, it was a teratoma. Fat density was seen within the lesion, and it was a typical example of anterior mediastinal mass. So everyone who said that hilum overlay and anterior mediastinal mass is correct. So this is a companion case of case 8. I showed you an anterior mediastinal mass. Is it the same, or there is something else in this patient? Companion case of case 8. Is it just an anterior mediastinal mass or something else? Memomediastinum. No, see the totality. I told you to hell with disease, have humor, be sober, all that. You apply that algorithm and then see. Is there something else? In this radiograph, LA enlargement. Okay, anything else? Left ventricle aneurysm. Okay, enlarged hilum convergence. Anything above the clavicles? Superior mediastinum. Yes, somebody said superior mediastinum and tracheal shift. Very good. So what you can see is, although this is an anterior mediastinal mass down, But what is happening to the trachea? Trachea is shifted to the right side. There is a large superior mediastinal mass also on the left side, and the margins are not clear. What this patient was a patient of lymphoma. He also had an anterior mediastinal mass as well as a mass in the neck. So this was a lymph nodal mass in the neck that was causing deviation of the trachea to the right side. So always apply your algorithm and see each structure properly before you comment whether the lesion is solitary or there are multiple lesions. Right, so I'll move the chat box. You have case 9. Case 9, what can you see? Case 9, anything wrong in this radiograph? Right paratracheal. Very good. Right paratracheal stripe is thickened and the superior margin is not well defined. So this is likely to be an anterior mediastinal lesion. Cervicothoracic sign is not positive. The margin is not clear. You can invoke the cervicothoracic sign and say that the superior margin is not clear and that's why it's likely to be an anterior mediastinal mass. So this I have already explained, set of images on first row and second row that helps you to understand what cervicothoracic sign is all about. Companion case of case 9. So I showed you one cervicothoracic sign. What is happening in here? There are two findings that you need to pick up in companion case of case 9. Yes, shift of trachea to left. Very good. So now you are getting the hang of it. The shift of trachea to the left, also left pleural effusion. There is a small subtle blunting of the left CP angle that needs to be picked up. Okay, now look at this radiograph. Anything abnormal? This is your case 10. Okay. 10th case, anything that you can pick up? Cardiomegaly, anything else? AP window, anything else? Left lower lobe consolidation. Okay, you are looking beyond the heart, right? Good, paravertebral, somebody said. So can you see this line? The convexity of the paraspinal line? Right. So here lies the issue. On CT that you can see is there is a large hiatus hernia with stagnant contents, food contents, and that is causing the convexity of the paraspinal lines. So actually the paraspinal tissue is not enlarged, but the para-aortic descending thoracic aorta line is showing convexity. Okay, case 11. This should be easy. Can you see this lesion? Easily seen? Okay, it is doing to the cardiac border? Cardiac border is pristine. Nothing is happening. It is not silhouetting the cardiac border. So where is it located now? No, it's not aneurysm. Anterior, no. Okay. Middle or posterior? Middle, no, because heart is not silhouetting. Yes, posterior. Okay, so let's have the CT. This was a neurogenic tumor that was arising from the vertebra and it was hanging like a teardrop over the rest of the tissue and it was causing adjacent lung reaction. However, this was a posterior mediastinal mass which was clearly seen. It was not silhouetting the cardiac border at all. So now there's a category change alert. Okay. So you were seeing all mediastinal masses. Then I showed you SPN and you missed. So I'm already giving you a category change alert. Look at this radiograph. This is case 12. Okay. I'm sure you would have picked up a lot of things happening in this radiograph. Yes, pleural base lesion, chest wall mass. Yes, lots of answers are coming. So what is the first is there? Second is also there. But where is the third and fourth gone? So it is completely destruction of fourth rib. Then again, third and fourth. Third rib actually. Then fourth is there, fifth is there, sixth is there, seventh. But the anterior ends of the ribs are not at all seen. You can count them here. Where are they here? So let's see what the CT showed us. Also, you can see these surgical clips. Can you see this? This is one thing that you should not miss because the patient has had a previous surgery. So this was a patient of CA thyroid, old operated masses, destructive lesions. So these were expansile lytic lesions of the which were metastatic in etiology, and they were causing destruction of the ribs, and multiple masses that were presenting as chest wall mass in the lesion. It was just the lungs are not causing are clear, so you can see that this was a definitely only a chest wall affection. Heterogeneously enhancing expansile necrotic lesions, complete destruction of left fourth rib was seen, and same thing was seen on coronal reformat. Now you can see what is this angle between the pleura and the mass. This is an obtuse angle. So this is a chest wall, or this is a typical example of chest wall lesion and difference between a parenchymal and chest wall lesion. Now coming to case 13. What is this? What do you see here? Lot of things to be picked up here. This is an example I have got because, however, normal reporting, if it comes, that maybe we can miss this finding. So there is an important lesion that is in the left lower zone, and it is pretty broad based, and it is extending towards the left mid zone as well. On CT, what we saw was there was large pleural effusion which was loculated at multiple places. There was septal thickening associated and calcifications also present. So this was definitely an old infection, and now the patient was having loculated pleural effusion. Companion case of case 13. Can you see any abnormality here? I'll give you 5-10 seconds to go through. Right pleura. Dr. Mehak has already told us, yes. So there is a convexity in the right pleura. There was a loculated pleural effusion, HU of 16 to 12. So typical case of loculated pleural effusion. Some cases come with just baffle you, and this was one of those. A child presented with a large mass, which was definitely mediastinal. Diaphragm was not seated, so it was not anteriorly located. Right away, we placed it in the posterior mediastinum, and same was confirmed on lateral radiograph also. I'll move the chat box so you can see the penetrated view. And in the penetrated view, you can see that the cardiac border is not well seen, and the ribs are thinned out because of the large mass lesion. There are there's splaying of the ribs in the seventh to eighth ribs. So this is likely to be a posterior mediastinal mass lesion. I'll close the chat box so you can see this nicely. Now on the CT, we saw that the lesion was posterior mediastinal, yes, but also that it was large lesion and it had few calcifications, nothing, not very enhancing on post-contrast images, and a myofibroblastic tumor was the final diagnosis. So we have to confirm the lesion, we have to see the location and extent of the lesion, and finally tell whether the lesion is benign or malignant. So what about benign or malignant lesion? Maybe I'll take 10 more minutes to finish this lecture, but we are just going towards the end of it. So when radiographs like this come to you, you have large mass with spiculated margins, acute angle with the lung parenchyma. You know that this is a lung cancer you are dealing with, and maybe metastatic nodules in the left side. It's not difficult, but what are the characteristics that you have to say when you are explaining the radiograph? You have to describe the mass or it is causing any collapse or unresolving consolidation, the size, margin, and contour of the mass, whether there is spiculated appearance or sunburst appearance. What is the attenuation of the mass? And does it have any calcification, cavitation? And wall thickness of more than 15 mm, definite doubt of malignancy must be kept in mind. Hilar adenopathy, pleural effusion, bony mets have to be described if they are present. and subtle lesions may be missed in the hidden areas. So do have a second look in the hidden areas. This was the corona radiata that I was talking to you about. Why it happens is because of differential growth rate within the nodules. Lobulations and speculations can happen, and they indicate that the lesion is likely malignant. Attenuation of the lesion. If there is fat within, you know that it is a hematoma and likely to be benign. If there is a positive bronchus sign, it is important to mention it, because then the lesion can be biopsied through a bronchoscopy. Cavitation, fluid level, and calcification types have to be mentioned in your description. Growth, very important. Volume doubling time in cases of spherical lesions, it means 26% increase in diameter. If there is 50% increase in diameter, it means 3 times increase in volume. Why is this figure of 26% coming? Because the nodule volume is taken as the volume of a sphere. Okay, and that is 4 by 3 pi r cube. So that is why only 26% increase in diameter causes a doubling of volume. Malignant lesions have a doubling time of 20 to 400 days. If a lesion doubles too fast, it is likely to be infective. And if it is doubles too slow, then it is likely to be benign. But the problem is with low-grade adenocarcinomas, which have a long volume doubling time. Contrast CT, you have to see wash in and wash out characteristics, and the well-defined the margins which have to be speculated. Hilar lymphadenopathy, pleural effusion, and metastasis has to be mentioned. Malignant lesions show washout because they have arterial supply from bronchial artery and venous drainage from bronchial veins. In washout phase from interstitial space, substantial decrease in lymphatic flow happens, and that may cause contrast retention at times. What are the limitations of contrast enhanced CT? It is sometimes very difficult to differentiate active inflammation from malignancy. If there is a lot of chunky, coarse calcification in the lesion, contrast CT becomes difficult. And lesions which are more than 3 centimeter will definitely show a lot of heterogeneous enhancement and necrosis. So this is the chest CT recap, and this is the format that you can use to describe a mass lesion on chest CT. MRI gives us a better soft tissue contrast, but it has limited role in cases especially like superior sulcus tumors, AP window lesions, or chest wall lesions. They will definitely give us a good hand. A few last cases. This is a radiograph of of an elderly female. And let me activate the chat box. So where is the primary lesion? What can you see here? What is the abnormality? Yeah, case 16. Where is the abnormality? Okay, somebody said left upper lobe. Okay, anywhere else? Left upper zone. Okay, right side lung is clear? All right. What I'll do is I'll show you some images of CT. So this is I'll close the chat box, and this is the non-contrast CT that you can see. So there is a large lesion with calcification on the right side also. There is destruction of lung, collapse of left upper lobe with chunky calcifications. So there was an old case of infection along with a lung mass on the right side. Post-contrast study also, and you can see here, this mass was showing heterogeneous enhancement with areas of necrosis, and the left side, left upper lobe was completely collapsed. The same thing was seen on the lung windows as well. There is a large mass lesion on the right side with speculated margins. What you can also see along with that is the nodularity of the fissures and mass lesions also in the other lobes. On the left side, there was volume loss and hyperinflation of the residual lung parenchyma. Coronal CT, coronal reformers show better nodular thickening of the fissure with a large lung mass on the right side. Deviation of trachea is there because of there is collapse of the left upper lobe. So this was a CA case in a patient of left upper lobe collapse. Where is the lesion? Yes, case 17. Where is the lesion? You can type in the chat box. Left upper zone, absolutely. So you can see a speculated lesion in the left upper zone along with another speculated nodule in the near the left hilum. So this is definitely, it is surrounded by lung on all sides. It is a simple parenchymal lesion as you can see on the lung windows. Speculated margins, multiple nodules. And along with that, there is hilar lymphadenopathy as well. The right lung is absolutely normal and the area of affection is mostly the left side. The patient was biopsied. We are awaiting the biopsy report, but yes, the first differential that was given was a neoplastic etiology. The post-contrast CT. Right. So with this, another case, last case that I'm showing you is that if a radiograph like this comes, you don't know where to biopsy the lesion. There is a lesion on the right side, but there is a lot of pleural thickening, calcification on the left side as well. So it is important to guide the biopsy to the right lesion. So there was second rib destruction on the right side, and the biopsy was done from the same place. To summarize, there are myriad tissues that can cause thoracic malignancies, and what our role as a radiologist is to confirm the location and the nature of the lesion. Case pearls I have shown you for various scenarios. Biopsy guidance is a responsibility of ours, and I hope that this presentation helps you for better patient care. So with this, we come to quiz time, and the quiz will take around 5-6 minutes. Let's go to poll, and I'll start the poll now, and you can answer the questions and I'll discuss the answers. So the first question, the poll is active now. You can answer on the poll. Quickly answer the poll because I have to discuss 15 questions with you. Which of the following is the most common anterior mediastinal mass in adults? Right. So if you have answered, then I'm not seeing anybody who has answered the questions. Okay, I'm ending the poll now. So can you see the results? Dr. Nikshita ma'am, are the results visible?
Yeah, I don't think anyone has answered. Some people have answered in the chat box.
Okay, ma'am. Then we'll take the questions in the chat box itself.
Okay, that's
Yeah.
fair. Yeah.
Right, ma'am. Right. So what I'll do is I'll activate the chat box and I'll keep it small so that you can, okay, if the poll closed early, then don't worry. I will discuss the answers in the chat box itself. Which of the following is the most common anterior mediastinal mass? Okay, I've got few answers. So that's thymoma. Always, you can answer by just answering A, B, C, D. Okay, that will be easier for you.
Um,
Just
Sorry to interrupt. Dr.
yes.
Ishita, if we can close the poll window.
Okay, ma'am. I'll just close the poll.
Thanks.
Okay.
Yep, this is fine. Just go on.
It's closed, ma'am.
Yes. Yeah, you can go on.
Yes. Okay, ma'am. Right, ma'am. Okay. So the first answer is thymoma. Second, a well-defined cystic mass located in middle mediastinum and closely related to carina is most likely bronchogenic cyst. Absolutely. Sutton is our Bible, so strict. You can read Sutton or Granger for your at least MD is good enough. Posterior mediastinal mass, which imaging feature strongly suggests a neurogenic tumor? Yes, most of you have correctly answered dumbbell-shaped mass with neural foraminal extension. Mediastinal lines, right paratracheal stripe should normally measure 4, less than 2 millimeter, 4 millimeter, 5 or 7. Okay, this is a mixed answers coming to me, but it is less than 4 millimeter. So 3 mm is the normal thickness. Anything more than 3 mm is abnormal. Which of the following mediastinal lines represent the interface between right upper lobe and superior vena cava? Fifth one. Okay, I got few answers and they are mostly correct. So right paratracheal stripe. Sixth question, a cavitating parenchymal lung mass with thick irregular walls in a chronic smoker most likely represents 6B. Yes, bronchogenic CA. Which of the following CT features most reliably suggests benign etiology of a solitary pulmonary nodule? Speculated margins, central laminated calcification, rapid doubling time, or lobulated contour? Yes, 7B, central laminated calcification tells you that it is benign. Which of the following features of SPN is most suspicious for malignancy? Question number 8. Yes, absolutely. Speculated border with pleural indentation is very suspicious for malignancy. Ninth question, posterior junction line represents interface between, where is the interface? That you have to tell. Okay, correct. Interface between right and left upper lobes posterior to the trachea. 10th question, which is the most common congenital cyst of the mediastinum? Okay, fine. Yes, most of you have correctly answered CC, so it is bronchogenic cyst. Question number 11, a mediastinal mass causing SVC obstruction with prominent venous collaterals in a 40-year-old is most often due to A, B, C or D. SVC obstruction with venous collaterals. Okay, this has varied responses. The answer is thyroid goiter extension. Coming to question number 12, which imaging feature is most characteristic of a teratoma? Yes, presence of fat and calcification in the mass. Option C. Question 13, which statement is true regarding mediastinal lymphoma? A, B, C or D? All right, question number 13, answer is A, almost always anterior mediastinal. Many of you have answered B also. Calcification is a common finding. No, it is not common before treatment. It is common after treatment. Okay. Question 14, pericardial cyst most frequently occur in which location? One example I've shown you. Yes, right cardiophrenic angle. Last question of the session, cervicothoracic sign. A well-defined mediastinal mass which projects above the clavicles on chest radiograph is most likely to be located in. Absolutely. So I'm so happy that all of you understood the cervicothoracic sign well. The answer is posterior mediastinal. So I will leave you with this thought. Skills are cheap, passion is priceless. But if you practice your skill with passion, that leads to greatness. So study well and all the best for whichever exams you're going.